So speaking first, we have Dr. Guillermo Shapiro and Helen Egger. Dr. Egger is a child psychiatrist and epidemiologist. She's chief of the Division of Child and Family Mental Health and Developmental Neuroscience. She's also vice chair for Integrated Pediatric Mental Health and director of the Duke Early Childhood Research Program in the Center for Developmental Epidemiology in the Department of Psychiatry and Behavioral Sciences. With Dr. Shapiro, she has been leading the Duke Information and Child Mental Health Initiative within Information Initiative at Duke. IID, that's a lot of information words.
Yeah, a lot of information.
Yeah, okay. Dr. Shapiro, her colleague, is a leader in image and signal analysis, both at the theoretical and practical level. He works on theory and application in computer vision, computer graphics, media imaging, imaging analysis, and machine learning. He's authored and co-authored over 350 papers in these areas, and prior to work at Duke, Dr. Shapiro held positions at the research facilities at HP Labs in Palo Alto, California, and the University of Minnesota. At Duke, he is the Edmund T. Pratt Jr. School Professor of Electrical and Computer Engineering. And I got a really early glimpse of their talk, and I was so excited that they were able to come today. Their talk is titled, Discovering the Unseen, Helping Children Reach Their Full Potential. Welcome, Dr. Shapiro and Dr. Egger.
Thank you so much. We're really pleased to be here. And I'm going to start off telling you about the work that we've been doing together. And this is a collaboration between the Duke School of Medicine and Pratt School of Engineering. And we really have embarked on building a platform to improve child mental health by bringing engineering and psychiatry and psychology together. So we're just going to give you a glimpse of the work we've been doing. So our work begins from the early childhood mental health field that had shown that 1 in 9 young children have an impairing developmental or mental health disorder. And this work comes somewhat out of my epidemiological work, but has been replicated globally. And this includes autism, anxiety disorders, ADHD, depression. But the key point here is not that children meet diagnostic criteria, but that these disorders are already highly impairing for these kids and for their families. The cost overall of developmental and mental health disorders is huge. So in terms of global health, 30% of all disabilities are due to mental health disorders. And the cost here, you can see the number of 2.5 trillion is huge. But very few children get any kind of intervention, mental health care. And for older children, it's only about 1/4 of kids who have an impairing disorder who get any kind of mental health care. But with young children, it's much starker. It's about 15% of those kids. So the majority of kids do not get any kind of help when they're young, and that really leads to particularly poor outcomes throughout the lifespan. So our group came together to answer, obviously we phrase it as a big problem, how do we address these problems? And speaking personally, this collaboration comes out of my frustration that we have so much knowledge within our academic communities that doesn't get translated out to change people's lives. And one of the bedrocks of our work is the idea that early diagnosis is key to really having an impact in the area of mental health. So what are the barriers? Access to care begins with screening and diagnosis with some kind of evaluation. But there's so many different barriers that lead to this lack of services for kids. There are not enough clinicians, and certainly not clinicians who are trained in early childhood mental health. The tools that we have are very, very expensive, take a lot of training, are very time consuming. So it's great. You can come into my lab over in Brightleaf Square in Durham, and we can do a bang-up 2-hour assessment of a young child and really be able to characterize the issues for that child and the family. But you can just go outside the walls of, even in our own clinical practice, but clinical practice more widely, and none of these tools are going to be used. Just to give you a sense of the access problem, and this isn't specific to early childhood, there are 100 counties in North Carolina 70 counties do not have one child psychiatrist. So these are not issues that we're just thinking about on a global scale, although they are global issues. These are right in our own backyard. We have come to the conclusion that one of the biggest problems is that our current approaches just don't scale. And that if we added more clinicians or trained more people or got more psychiatrists out into this community, we're never going to catch up and really make a dent in the problem. So there are two pieces of sort of insight that are driving our work that came from this. It's not just that doctors and clinicians need knowledge about early childhood mental health and how to identify problems. The people who are with children every day, parents, teachers, child care providers, grandparents, they're the ones who have to have access to evidence-based knowledge and then information about what they're supposed to do with that knowledge. So again, we think that information science and technology is the key to really trying to really have a paradigm-changing shift in how we take care of early childhood mental health. So here's a picture of the Duke Information and Child Mental Health Initiative, and what this graphic really represents is how many different parts of Duke are involved in this initiative. So you see we've got on top the Pratt School of Engineering, Duke Medicine, but we also have folks in the arts and sciences, and the Department of Psychology, other departments that are involved. And we're also engaged with all of the different institutes because Duke has a lot of different interdisciplinary opportunities. So the Duke Institute for Brain Sciences, Global Health, Center for Child and Family Policy. We're trying to bring together all of these different interdisciplinary strands, as you pointed out, in the keynote address, that these solutions are not going to come from dyadic collaborations. They're really going to come from people coming together from very, very different points of view. And I can tell you, having worked now for 2 years over at Pratt, I'm a child psychiatrist, what am I doing over in an engineering school, has been exhilarating and an incredible learning experience, because we have a lab meeting every week for 2 hours with our psychiatrists, psychologists, engineers, data scientists, and we got to learn to talk to each other in that room. And so having the experience of saying, here's the problem of what we want to measure, and then having the engineer be able to say, okay, we understand that problem, we're going to go make something to do that, and then we come back. It's a tremendously exciting experience. So the other piece that I really want to emphasize is that we see this when we say global community here. I emphasized our local problems with access to mental health knowledge and care, but this is a huge global problem. I mean, there are countries that have no child psychiatrists or mental health care, or 10. So that if we can find solutions that are accessible, not expensive, and of course evidence-based and actually useful, this really will have the opportunity for us to build a global community and also improve access to all children. Now I'm going to sort of drill down into work that we've been doing in the area of autism. We see the scope of our work as being broadly across early childhood, emotional and behavioral and developmental issues, but we have started with autism, and Dr. Jerry Dawson, who is now leading the Duke Autism Center, is our colleague who's not here and be representing the work that all three of us, along with Robert Calderbank, are doing together. So autism is a growing issue. This just shows a graph from 2000 to the present of the increased prevalence. Now the estimate is that 1 in 68 kids has an autism spectrum disorder. And here, this shows our number of autism-related clinical visits at Duke Medicine. And you can see over this time we've had a significant increase. We still have a 12-month waiting list for kids to be seen at Duke. And this is within an area where UNC is one of the prime autism centers in the world. And even within this incredibly rich environment, parents can't get to an expert to get help. Now, why does this matter? We kind of know in a big way why it matters, but I think this illustrates it. So now there is, evidence-based tools that enable us to diagnose autism at 18 months. But the mean age that a child in the US is diagnosed with autism is 5.3 years old. And this is during the time of incredible brain development. Of course, children are building their cognitive, social, physical skills, but we know that this is when a child's brain architecture, the time from 0 to 5, is really established. And here's just to illustrate it, that there are 700 synapses a second that are connected during this very plastic and fertile time of brain growth. So by missing this gap, we are really missing a real opportunity to develop healthy children. So I'm going to turn to Guillermo and just and have him illustrate how we took the issue of autism and where our approach is to take a disorder or a problem and break it down into its smallest pieces. And one example here is children with autism often don't turn when their name is called, or they do not respond in the same way to a simple baby game or some kind of interaction. And we define those of us on the mental health side, and then we collaborate with our engineers to figure out ways that we can measure these phenomenology in a way that will be able to reach many parents. So I'm going to let Guillermo show you the work we've been doing.
Thank you. Thanks, Helen. Thanks, everybody, and thanks to the organizers for putting this together. Only one thing upsets me about this conference. The meeting that Helen says on Wednesday mornings.
Yeah, exactly.
So we're missing it, and that's some of the two most exciting hours we have in the week. So some of the members are here, but please do not organize this again on a Wednesday morning. So one of the things that we want to do is, I just want to give you two take-home messages before I show you some of the examples. One is that we have three great members from the medical side in the team, Helen, Jerry Dawson, and Jeff Baker, a pediatrician that is actually helping us to test this in his clinic right now. We have done a number of cases. And one of my goals is to put them on an iPhone. Basically, their knowledge has to go on a phone. That's basically the goal. It's the only way to make this scalable. It's not training more doctors, more practitioners. That will never happen at the scale that we need. So that's kind of our goal as engineers, is to put their core knowledge. The second thing I learned in these couple of years, so I do a lot of brain science in my multiple lives that I have in my academic career. But when you ask Helen, Jerry, or Jeff, what's the ultimate way that you use to diagnose, they say behavioral analysis. No brain science, no genetics, no nothing. We are very far from getting there, is observation. So that's what we're trying to do. How do we put on a phone or on a tablet the knowledge of observation, which is the most challenging part? So this is one example that basically a clinician is showing a toy to a toddler. In this case, is the sibling of a kid that has been diagnosed with autism. And we are automatically tracking the head position and telling you frame by frame if this kid is looking at the toy or not. She basically went from left to right, and we're tracking frame by frame the position. So we basically completely took out the coding from the person. If you know how the person is doing it now, she's kind of moving this and basically counting in her head 1, 2, and how long it takes the child to shift attention. And she's doing multiple things at the same time, and she has to follow a specific protocol to do them. And we say, just forget about it, just show the instrument, and we're going to do the coding for you. And by the way, we don't count 1, 2, we count 30 times per second. So we give you every frame what's happening, and that's a graph that we have there. That actually we have validated, and it outperforms students in psychology, and it outperforms a child psychiatrist that is not an autism expert. So we're doing better than the access that only less than 1% of the population has. Most of the population doesn't even have access to that, so we can outperform that access. So all what you have to know is just move the toy, and that should be enough. So that's one example. The other example is that we are basically, and these are stimuli that were designed by Jerry Dawson, and there is sound, but we're not connecting. And the child is watching this movie, and we are looking at his or her facial expressions. And they tell me in their research that when you're watching this, if you're normal, you should smile. Or if you're watching this, if you're normal, you should get scared. And that's what we're measuring. And basically, I can show you that. This is a normal kid, the son of some of our members. And we track all the facial expressions that you see on the bottom. Are you surprised? And they know what to expect in normals and what are signs of concern. And I just want to use this opportunity to tell you that we don't dream and we don't want to diagnose. We're just screening and giving you at the end of this 5-minute test a warning or a recommendation with a phone number and a link that you should be following up. And I try in my ignorant engineering mind to do an analogy that kids get screened for eyesight and they get screened for hearing at schools, and they don't get glasses. At school, they just get a referral to a doctor, and that's what we want to get. So we want to get to the point that the kids get screened in 30 seconds for eyesight, 30 seconds for hearing, and in a minute for basic mental health. At the end of those, you get a referral. You don't get drugs for ADHD, you don't get glasses, or you don't get a hearing aid. You just get a referral. That's what we want to get to. And that's basically our goal with this type of tools. So now I have a Mac person trying to run a PC. Just don't ever do that again. So this is one stimuli, and this kid is actually watching it in the clinic. Actually, this was a Brightleaf, but we're running both volunteers in the clinic at Brightleaf. Once again, he approved. We cannot show you the kids that have been diagnosed because all of them so far have not approved the teaching component of disclosure. This kid is normal, and the mom approved that we can show the video for teaching goals like this one. So this kid is watching it, and then at the end, basically, so he's doing expressions, we're automatically tracking his face, his expressions, we're automatically doing all that. And we have another stimuli I'm going to skip, but this is a very nice video of toys playing with each other. And they tell me that they know what to expect. I'm not saying that. I'm not asking those questions. They come, as Helen was saying, and say, could you track the facial expressions and see at a certain point, basically the toys are falling, and they know what to expect, and we're tracking that. So that's kind of the toy, and the kid is watching that. And I'm going to just try to skip. This was designed by us. So there is a number of these that we designed, and the kid is watching all what's happening, and we're tracking everything. I'm not showing you now, but we're tracking everything. And at the end, we provide either frame by frame, or we provide graphs like this. And in normals, you expect a lot of facial expressions during those few minutes. If they're not normal, you expect much less. So every video or cumulative, that depends on the statistics that they want, we can show you how much he was smiling, how much he was distracted, how much was not watching the movie. We just completely turn around. We detect that automatically. So we do all the coding automatically. And these are examples, and you can see from these examples some of the kids that were diagnosed, actually, because as I say, they go to Jeff Baker's clinic. You see that they basically are watching the entire movie with almost no facial expressions. So you don't see these cumulative facial expressions going very high compared. So these are all videos that have been designed to stimulate the kids, either smiling or surprised or worried. And you see, if you were allowed to watch the movies, you see that they kind of have no facial expressions. Some of the kids are really watching the movies, but they don't express anything. And then at the end, we give these graphs. And that's also very important for privacy issues, because when we get to the stage of distributing this in the homes, we don't have to see the videos. All the analysis is going to be done in their home. And this is very, very different than other people that are saying, send me your video from Timbuktu, and I'm going to tell you what happened. I don't want to send you. the video. We actually hosted the other day an expert in this area, and they say in the community I work with, actually some of these things are shameful to the family. So they don't want nobody to know because they know these are genetics, and if I find that my boy's son has autism, nobody wants to marry his sister. Okay? So I'm not going to tell anybody about this, and they will never agree to send you a video, but they will agree to do the test at home, and maybe send us only this at the end. We've never seen it, or maybe not even that. And that's why this is important, that we can do all the analysis on the spot. So this is at the individual level. Our goal, and the goal is going to come very soon, is this is going to be distributed to everybody, and that will actually help us to basically gather new science and understand more, because I keep asking Helen and Jerry as experts, how many kids you see in your lifetime? And they say maybe a couple of thousands if I'm lucky. You can't do data statistics with a couple of thousands. The fortunate part of humans is that we have a big diversity among ourselves. So we might be able, for the first time in history, to collect child behavior data in the hundreds of thousands of millions, and maybe do new science with that, at the same time when we're helping every individual child. So that's part of our goal. It's very modest or very ambitious goal, but we want to go modest steps at a time. And the part I want to say, because this is very important, the entire Duke University is behind us. They have been supporting us with space, money, everything that you can think about, coming and knocking with a crazy idea from the president to the provost. Both the medical school and the university have been nothing else but extremely receptive with this, even when we have, what I show you is from the last couple of months. What we had for the last 2 years was only the first slides, the idea. Now we are having this, but Duke has been supportive from the very first slide. Say, go for it, and we will figure it out. And we're trying to figure it out. So this is all Duke, and we're about 30 people involved in this, and there's a few programmers that now are sitting in the room. The group is growing, and we are just basically the presenters, but the students are doing a fantastic job behind this. Okay? Thank you.